Hello students, this is Physiology of Phonation. We want to start off by just reiterating the most important function of the larynx. We always mention biological versus non-biological function, and in this case you should be able to answer this question that airway protection is the most important function of the larynx. We can also obviously use the larynx for phonation, but the most important function is airway protection. Coughing is another evidence of, or an example of airway protection. And if you think about how coughing occurs, the vocal folds have to come together with significant force, and you're also expelling air up from the lungs through the vocal folds to blow out anything that might be in the airway, either above or below the vocal folds. So coughing is just an example, one example of airway protection and keeping things out of the airway. And as we've mentioned before, another way that we protect the airway is that very tight closure of the vocal folds. When we think about the vocal folds being either open or closed, I mentioned before that it's not an all or none thing, so that closure can be really tight or relaxed, or it can be wider and a wider opening. And the degree of opening will depend on the function that for that particular task. So as we look at this diagram, I do want you to understand this figure and be able to identify from the picture what the function is for that particular posture or position of the vocal folds. So for this first one that the arrow is pointing to, it says that the vocal folds are dilated for forced respiration. So let's take a look first of all and get oriented to what we see. The yellow bands are the vocal folds, obviously. This structure here is the thyroid cartilage. Hopefully you're saying that right along with me. This ring that we can see is the cricoid cartilage. Remember that we have the arytenoids that are on top of the back of the cricoid cartilage, and we have the vocal process that the vocal folds are connected to, and then you have the muscles that are connecting also. Now for forced respiration, you want to have very wide opening of the vocal folds, so you can see in comparison to the other pictures, the vocal folds are wide open. And there's one muscle that is used for AB, abduction, for wide opening of the vocal folds, which you should know, and it's the posterior cricoid arytenoid, or PCA, and that's one that you should know. So here they are wide open for the purpose of dilating the airway for forced respiration. So this is when I would say to you, take in a deep breath, and then so you just open the airway as wide as you can. You're going to stretch the vocal folds open as wide as possible to get in as much air. So looking at this picture in contrast to the others, you should be able to easily identify that the position of the vocal folds here is for forced respiration. Now I'm going to go right below it actually and go down here. So here we say that the vocal folds are adducted, ADD, adducted for phonation. Now what you see in this picture is that the vocal folds are close together. You see that they're not tightly slammed against one another, because remember that in order for the vocal folds to vibrate, there needs to be enough space so that the air can come up, and as the air comes up, then that will allow the mucosal wave and the closure to occur, which is actually coming in a slide to come. So you can see that the vocal folds are close together and much close enough so that air can come through, and we can have phonation and have that mucosal wave. So in looking at this picture, you should be able to identify that this is position of the vocal folds here is adductive for phonation. As you look over here, you can see the vocal folds are close together here, more anteriorly, but wider opening here in the back. So this position is AB, abductive for quiet respiration. So they're open, they're relaxed. So this is as you're just sitting there doing vegetative breathing, the vocal folds allow for the flow of air to come and go for the purpose of respiration. Now, even though you're seeing this clear space here, please know that this is all covered up, right? Yes, this is all covered up. False folds, other muscles, membranes, etc. So we're really wanting you to focus looking at this opening here of the vocal folds. That's what we're talking about. So quiet respiration, airflow in and out easily, no problem. Now, the last one, as I go back here, is AD, adductive for whisper. So I don't know if you've ever been told this before, but let's say that you have, you've been hoarse or you have a voice problem, you're having trouble, your voice is hoarse and you want to speak to someone, and then your instinct might be to just whisper. But whispering actually is not it's not something that we recommend if you are having any type of issues with voice. So for whispering, you can see that you have to actually push your vocal folds together pretty closely, and then you're forcing the air through. You're forcing the air through, just in case you couldn't hear what I said, but you're actually preventing that the mucosal wave, because when we do this, we're usually whispering in someone's ear. So we're trying to be quieter and not allow the full voicing to occur. So if you even do and take yourself, I want you to take yourself from saying to whispering, and you can actually feel a tightness in your throat as the muscles actually push together to for this tight closure. And then what you're doing is just squeezing air out, and that's why we hear that breathy sound, but it's not really the voice that we're hearing. Okay, so that's the picture that you see. You should be able to identify this picture as adducted for whisper. Okay? Now, the way that we phonate is that we have air originating in the lungs. It's going to, the lungs are very wide or much bigger in relationship to the trachea, right? If you think about the expansion of air and then coming to a smaller area of the trachea, and then an even smaller area to come between the vocal folds themselves, okay? So we have this air that's going to come up right under the vocal folds to push through this small area of the vocal folds. So we go back to principles of physics, just as we saw in respiration. Here are principles that are involved in phonation. So we have Bernoulli's effect and Bernoulli's principle. So here's the definition of Bernoulli's effect. And then what's actually happening is that we get this vibration and closure of the vocal folds is the result of an inward sucking movement of the medial margin of the vocal folds, caused by the rapid flow of air moving through the vocal fold margins, producing negative pressure, causing the folds to be pulled together. Now, I know you can read this, and hopefully as you look over the words, I wanted to say them out loud first, but what it is that the vocal folds are close together, and then this airflow being sucked through this small space is what's causing the vocal folds to be sucked together to start off this mucosal wave. Now, as we look at the next slide, Bernoulli's principle, this, again, we talked about physics, we talked about respiration, and if you let's look at the description and then this diagram. So the velocity of gas through a tube was inversely related to its pressure against the side of the tube. Velocity is greatest, it means fastest, and pressure is lowest at the point of constriction. So what happens here is we have all of these molecules, and then they're being pushed through this small space. The space is much smaller than here. So we get negative pressure, a drop in pressure, and we also get a more rapid flow as we go through that space. So velocity, speed is greater, and pressure is lowest, which is actually negative at the point of constriction. So the point of constriction is the vocal fold. So remember, air is coming up through the lungs, which are and through the trachea, which are all bigger spaces, and then you have this tiny space between the folds, and then jutting up, and coming out through the oral or nasal cavity. So this is Bernoulli's principle, and what this explains for us is how the vocal folds are actually able to have that wave. So in this picture, what I've done is then do a side-by-side of the larynx, and this is coming up from the trachea, showing you've got wider spaces, then you have this really small space. So right through here at the level of the vocal folds is matched up with this area here in terms of a smaller space. So you're going to get this this drop in pressure, negative pressure, that's going to pull those vocal folds together. So what we do, we call that the mucosal wave. And the vocal fold itself is very moist. You have mucous membrane. You probably know for yourself that if you're very dry, like you haven't hydrated enough, and you notice, you can even hear it in your voice, because it has good healthy vocal fold, has a lot of moisture, and it's very flexible and fluid. So as you've seen on the videos, you've seen how the vocal folds come together. They don't really just like clap back and forth like hands, but how there's actually a wave. And so this movement of the vocal folds, this mucous membrane outside covering of the vocal folds is actually referred to as a wave. So as they, let's go up here to 1. So as the vocal folds are together, and you have this air flow coming up from the lungs, you'll notice that the vocal folds start to open. And so when we say from inferior to superior, we mean air coming up from the trachea and touching the lower edge of the vocal folds, and then starting to push them apart. So pushing them apart more, then they separate more, they separate, and then you start to reverse and they start to come back together. If you notice, as they start to come back together, they come back together at the most inferior point, and they close from inferior to superior, just like they open from inferior to superior. So that's what we mean when we say that the opening is from the bottom to the top, and then they close from the bottom to the top as well. So that's the mucosal wave. Now I'm going to click and see if this link will open up. I've been also having trouble with my computer. I think I might have to get a new one, but I'm having trouble with sound, and I'm having trouble with it shutting down a lot. So hopefully I don't lose you on this. But what I want to pull up is just seeing a video of that mucosal wave. Now, I had to turn off the sound because the sound on my computer is very wobbly. As a matter of fact, it kind of sounds like a voice disorder. Okay, let's see. I might need to pause this while I'm waiting for this to come up. Bear with me for a second here. See what's happening. Oops. I'm going to pause. Okay, so we're back on now, and let's take a look at the mucosal wave. So what you're seeing here are the vocal folds coming together, and let's see, I think it's a little bit supposed to be slow, but it might actually be a little slower than it's supposed to be. There we go. So you may be able to envision that it is closing from the bottom to top, and okay, looks like that's there we go. Okay, and so the person is also voicing, but as I said, I had to turn off the sound because it's not sounding properly on my computer. But I'll have this link next to the slide so that you can also see it. And again, the purpose of this is to see how vocal folds are pulled together, and then air is coming up, and then you can see the mucosal wave occur as they open and close like a wave. From bottom to top they open, and then from bottom to top they close. Okay, all right, so that's an example of what the mucosal wave looks like. Okay, so now when we talk about I'm going to talk about the different phases of phonation. So the first phase is the attack phase. What that means is that the vocal folds are just coming together to get in position. So that phase is called the attack phase. It just means that the vocal folds are going from an open position, maybe that relaxed position that we saw, or it could be from that forced inhalation, like taking a deep breath before you start to sing or speak. But then the vocal folds are brought together so that they are close enough to vibrate for phonation. So that glottal is, and so that initiation is, or that bringing together of the folds is called glottal attack. Now sometimes in some individuals, particularly if individuals have some type of a voice disorder, that glottal attack may be too forceful, or this could be a habitual way that that person has of speaking that could also lead them to having a voice disorder. So for example, as I am saying 80, 81, 82, 83, 84, that should sound pretty normal, except for the little congestion that I have that you may be able to hear. But if I were to have, and should be a normal glottal attack in terms of how I'm bringing my vocal folds together. If for someone who has a really hard, what we call a hard glottal attack, that might lead to voice problems. See if you can hear the difference. So first I just said 80, 81, 82, 83, 84. So if I have a hard glottal attack, it sounds like this: 80, 81, 82, 83, 84. So you can hear that extra force as I'm bringing the vocal folds together. If I was always talking like this with this hard glottal attack, then I would be more prone to having, laryngitis, irritation of the vocal folds. If that's occurring all the time excessively, then I might start to develop further voice disorder, something that would not be temporary, but something that would be more permanent, like vocal fold nodules, for example. But normally we all have this attack phase, and the idea is that this bringing the vocal folds together should happen, in an easy fashion, but it can be overdone in such a way that this could be more abnormal and lead to an issue. But everybody has this attack phase. Okay, and then once the vocal folds are brought together, then you begin to stream the air through the vocal folds. You have that that's the sustained phonation. So the vocal folds are held together in place in that position, as we just saw in the video for the mucosal wave, that they're held together so that the airstream can continue to go up and the vocal folds can continue to have that mucosal wave or vibrate, and we can hear the voice production. And then the third phase is termination. So termination means that the vocal folds are AB abducted, pulled apart. There's only one muscle that we mention again, that AB abducts the vocal fold. I'm not going to say it again. Hopefully you can say that, and if you really don't know, take a look back in your notes, because that's one muscle that you should certainly know and remember. So 3 phases of phonation: the attack phase, the sustained phonation, and the termination. And this is all normal phases of phonation for all of us. So here's some concepts to know, and that we'll go back and forth and talk a little bit more about these. But frequency, right? So frequency is the rate at which the vocal folds are vibrating, and we hear or perceive frequency as pitch. So when we say, oh, that person's voice has a very high pitch, or that person's voice has a very low pitch, what we're actually perceiving as pitch is the frequency, the amount of vibrations or how fast or frequently the vibrations are occurring. And that's going to be different for male versus female or children. And I'll mention something about that coming up. Also for pitch, we all have what's called optimal pitch, and then there's habitual pitch. Those two should be the same. So the optimal pitch is what is comfortable for you, where there's no strain. It's also tends to be linked to your gender, because the size and the thickness of your vocal folds, as well as your laryngeal mechanism, would there would be a tendency to be either higher or lower. And so what's optimal is also, you know, what's comfortable. And if you think about it, like if you had two men side by side, they, you know, their voice doesn't, one voice might sound a bit deeper, but then if you had a man versus a woman, oftentimes you can distinguish who's who because of the pitch. But optimal means that you're not straining, it's comfortable for you, and that's the optimal pitch. Habitual pitch is the pitch that you normally use every day. So for most of us, our optimal pitch and habitual pitch are the same. That's good, and that means that we're not straining, and it shouldn't require any additional effort, and then we probably won't be developing any vocal disorders just based on misuse of pitch. Now, let me give you an example. Let's say that I just really want to try to be very forceful and authoritative. So by doing that, I just habitually use this pitch that is much lower than what should be a pitch for me. I mean, you also are hearing some hard glottal attacks, but I can really push my voice down and make it sound you know, lower, and this really isn't the optimal pitch for me, but I might do this. Maybe I have this job and I'm competing with a lot of, you know, men in the workplace, and I really want everybody to know that I, you know, don't take any stuff. So anyway, but by doing that, I'm also using a lot of extra muscles and tension, and can develop, you know, a voice disorder based on my excessive use of muscle tension, and began to develop issues with my voice, such as vocal nodules. That's one of the most common, so just using that as an example. There's another one that I'll mention again later, but there's a condition called puberphonia, where a young man whose voice is changing and going through the pitch change of adolescence. And, you know, for a prepubescent teenage boy, the voice could sound pretty high and might sound not so unlike, you know, girls around that same age. But with puberty, then that voice becomes deeper. And for some boys, as they're going through this, might feel uncomfortable. But there is a disorder called puberphonia, and it's not common, but this is where the pitch is changing and the voice is cracking, but it seems more comfortable for that person, that young man, to keep his voice at a higher pitch. So even though physiologically the mechanism is changing, the larynx is changing, the lower pitch is the pitch that should be the optimal pitch, but he might continue to use a much higher pitch because he's not really accepting that voice change. So this tends to be more of a behavioral condition, and again I'll mention it again later, that puberphonia. So in that instance, optimal pitch, because the voice has changed, testosterone has kicked in, there's, you know, more physical growth probably also of the laryngeal area, and where you might expect that the voice might go, you know, all of a sudden be deeper, so that young man might sound more like his father, but he'll just continue to speak in that higher voice and sort of hold his, continue to hold on to that higher pitch when his voice should really be down here. So what's optimal would be down here because it's effortless. But a habitual pitch is the voice that he's holding on to. So that's an example of where optimal and habitual are different, as I explained earlier, and for the person who is trying to use a more lower voice than usual. Okay, so how does pitch change? We'll be talking about that as well. So there are some elements that help in changing pitch, and we'll talk about that later. Intensity. What is intensity? Intensity is perceived as loudness. So, and I think that's pretty straightforward. Voice quality is another characteristic of the voice. So we might say that person's voice sounds normal, or that person's voice sounds hoarse, or that person's voice sounds, I think this is more breathy and this is more hoarse. It's kind of hard for me to do these things. Today, I'm usually pretty good at doing these things. Yeah, so hoarse, you can kind of hear hoarse. And then breathy is like this because there's still like a lot of gap between the vocal folds. So vocal folds approximation, bringing them together is still a little bit far. I'm not whispering, I'm just not bringing the vocal folds together as much as I could. So I'm not getting as much as a good wave so that you can actually hear the voice. Also, the voice has different registers, vocal registers, and for people who are singing or who've taken voice lessons, you might have heard these terms before. So modal register is sort of your normal chest register, and again, what's pretty comfortable in speaking. But glottal fry is when you're really low glottal fry, and you might actually hear that. There we go. Having a little trouble changing my pitch today. But glottal fry, sometimes people will use it. A lot of times when people wake up in the morning, they might have glottal fry. So, and then there are some people, again, who use glottal fry habitually, so that it's more of a behavioral issue. Falsetto is that really high-pitched voice that a person can use for singing, for example, and get all the way up there in the falsetto voice. I'm going to pause for just a second. Okay, so in your other tasks, you will have some examples of glottal fry as well. I won't add that on here. So for vocal intensity, just a bit more information about that. It's measured in decibels, which you should be familiar with from your audiology class. So as vocal intensity increases, the perceived loudness of the voice also what? So hopefully you would say increases, right? Because vocal intensity is perceived loudness. So if you increase intensity, that means it's an increased loudness as well. Now, in order to change vocal intensity, this is what's necessary. The vocal folds have to stay together longer during the closed phase. You also have to have an increase in subglottal pressure. Subglottal pressure, remember that the glottis is the vocal folds, so subglottal means below the glottis. So this means more air, coming up to the vocal folds, subglottal pressure. You also need to have an increase in medial compression. Medial compression is just the vocal folds coming together at the midline, so that means coming together with a bit more force to increase intensity. Now, if you were about to yell across the room, just think, or even if you're by yourself, just go, hey, or just start to yell and then just stop. When you do that, you probably notice that all of a sudden you took more air, you took a deeper breath, so that was increasing your subglottal pressure. You also should have noticed more tension in your in your larynx, in your neck area. So you are actually preparing the muscles to squeeze a bit more. That's increasing your medial compression. So you automatically do this when you get louder without even thinking about it, but these are the things that you need to do to get louder. Vocal folds stay together longer, increase subglottal pressure, and increase the medial compression, which is the force at which the vocal folds are coming together. So if you're going to yell across the room, first thing you're going to do is take a deep breath, for example, and that's increasing your subglottal pressure. So thinking about that, something that we do naturally. And now I'm getting glottal fry without intending to. Again, going through a lot of sinus issues here, so don't have the best control over my voice today. Okay, so when we think about voice quality, again, quality are things like whether it's normal, whether it's hoarse, it could be pressed, meaning that you hear more tension in the vocal folds, or it could be breathy. So, you know, that tightness of the vocal folds, more pressed or breathy, as I indicated before. And we can hear that, and we would describe somebody's voice as sounding breathy or hoarse. So a little more information on vocal register. So it's indicated here. And so modal, as I mentioned, that's your normal conversational register. The glottal fry is low and crackly and can even be measured as low as 30 hertz, 80 to 90 hertz. And falsetto is at really high, you know, speaking way up there, you know, where the vocal folds have been really lengthened and thinned out in order to get that falsetto. So how does the voice differ between genders and across the lifespan? Well, fundamental frequency it does there are differences in fundamental frequency based on gender. So for men, the average fundamental frequency is 130 hertz. The average fundamental frequency is for women is 250 hertz. Remember that this is average. And also, as you're speaking, your fundamental frequency is not just at one level. You know, even with things like suprasegmentals, and you kind of go up and down in your speech as you want to emphasize things, or you know, up or down. So that average, like if you're measuring fundamental frequencies, that measure, you know, you would take a speech sample and come up with an average. So, and even within men and women, there's a bit of a range, but these are just some good markers to use, you know, sort of as a, you know, some frame of reference in what you would expect. Now for infants, you know, you can imagine that really sharp, high-pitched cry that you hear of infants, or that squeaks that you hear from infants. So that fundamental frequency could be up to 500 hertz, and the average being 400 hertz for infants. And then, as we mentioned, that starts to change around age 12, around puberty. So for males and females. And you may have even had an experience yourselves at home in answering the phone, for example, over the phone, where someone might all of a sudden they hear you on the phone and they think that you're your mom or your dad, and many, you know, several people have that experience where all of a sudden as people are listening, not seeing their faces, and they say, oh, I thought you were your mom or your dad. And that's typically heard around the time of puberty as a person's voice starts to change. And so these differences in fundamental frequency are going to be related to vocal fold length and mass. And as I've talked before, when you think about the length of the vocal folds, usually longer and thinner tend to give you a higher pitch than a broader, fatter, thicker vocal fold tends to give you a lower pitch. And you can see the same things occur on the strings of an instrument. So violin strings, guitar strings, even if you look inside of a piano, and you'll see that there's a difference in length and mass of the strings inside the piano for high versus low, that correspond to high versus low pitch or fundamental frequency. Now, so now talking about voice and gender. So speech-language pathologists do specialize in working with individuals with transgender voice and transgender communication. That's a specialty area. That's not my area of specialty, but this is a good opportunity to talk about phonation and the actual vocal folds and the characteristics of the vocal folds, and also communication in general when it comes to perception of gender. So for transgender communication, when we think about whether or not a voice sounds male or female, the fundamental frequency that we perceive as pitch certainly gives us one aspect where we might not see the person and make a determination and as to whether or not we think that guess that person's gender. But that's only one aspect of gender, so the frequency of the vibration of the vocal folds. The other is the voice resonance itself, so the physical body and size characteristics, and the other is speech prosody. So all of those components together will give a perception of whether we think a person might be one gender or another. Now, what I mean by the physical body size in terms of the resonance, that's just the characteristics of, you think about the neck, the throat, the chest, might be larger, smaller, narrower, deeper, and so that the voice, the characteristics of the voice will sound different just because of the size of the person and how they're made, really. And if you think about musical instruments, for example, you can have, if you read musical notes, you can play the same note on a guitar or piano or flute, but that note is not going to sound exactly the same, even though it's the same pitch per se, because of the characteristics of that instrument, the size and the way that it's even made. So that's what we mean. So that's one thing that you can't really change on a person. So that resonance will make a difference. But speech prosody, your suprasegmentals and other characteristics of your voice, there are some tendencies that may differ between genders, and that is one of the things that people might be working on in voice therapy. So in terms of surgery, actually changing the characteristics of the vocal folds so that they would change the frequency vibration. For voice masculinization, surgery is really rare. Typically, just giving testosterone will actually make the voice deeper, and that's typically all that is needed for in most cases. For voice feminization, even though you give hormone treatments like estrogen or testosterone blockers, that doesn't affect the voice at all. So it doesn't make the voice change and become higher. So surgery is more, is something that people might seek more to have the voice sound more feminine. And then also therapy might be used again to help with modifying some of the other aspects of communication, like speech prosody. And then there are different ways that the voice can be changed to feminize through surgery. So there's a website that I'll have a separate link to that you can click on and get more information about how that's done. Another thing with voice, now just this with normal voice, There tends to be some difference between genders. As we mentioned before, fundamental frequency is typically higher in female than male voice. But you also have some changes in fundamental frequency across the lifespan with aging. So women will tend to, with age, so for older women, they may have lowering of fundamental frequency. So you might have a woman who maybe when she was in her 20s or 30s, her voice sounded one way, but then as the woman is, let's say, 65, you might notice that her voice tends to sound lower. And some of that has to do with changes in the vocal folds, but the other may be related to the hormonal changes. In men, there may be some slight increase in fundamental frequency over age 7, according to one study that was, some studies that were done. So there might be a slight increase so that older men, their pitch might sound just a bit higher. Again, we know for them that it wouldn't be because of the hormonal changes, but more likely to do with changes in the vocal mechanism itself. So I'm going to just mention a few changes that we'll see in the physiology of phonation, or a few aspects of the physiology of phonation that might lead to some voice disorders. But first of all, when we think about phonation, what's important to think about are the aspects of subglottal pressure. We mentioned that's the buildup of air coming up from the lungs and through the trachea. There's also the concept of tissue elasticity. So that tissue, the vocal folds, needs to be really flexible. You saw the mucosal wave, and you see that there needs to be quite a bit of movement and free movement. There's also constriction. So that is also, the coming together to produce phonation. So the interaction of subglottal pressure, tissue elasticity, and constriction will produce phonation, as long as pressure, flow, and vocal fold approximation are maintained. Now, vocal fold approximation, as I mentioned, is the vocal folds coming together for the purpose of phonating. So they need to come together, close enough to vibrate, but not too close, and not too far apart so that you don't get breathy voice. Okay, so let's take a look at these things. So let's say that your subglottal pressure is insufficient. So you're not getting so much subglottal pressure. What would happen? How would that affect phonation? So this is what I want you to think about, all the things that we said, sort of putting everything together. Now, the first thing I had was, how would it affect intensity? And you might remember that we had a slide that said in order to increase intensity, one of the first things that you needed to do was increase what? Subglottal pressure. So if you can't increase the subglottal pressure, if subglottal pressure is insufficient, then you're going to have a lower intensity or softer voice. So if you think about it, this is also, if you have someone who has respiratory issues, for example, if they can't get a lot of air flow, then they're going to have trouble having a louder voice. Their voice is going to tend to be softer. And that makes sense, right? Also, I already hit it a little bit early, for changes in pitch or fundamental frequency, remember that as we want to go up in pitch, sorry for that really bad off note, but if you don't have enough subglottal pressure, if that's insufficient, then you'll tend to stick with the lower pitch or have a reduced pitch range. And then in terms of equality, if you don't have a lot of good airflow, good subglottic pressure, then that voice tends to be weaker. So if you think about someone who is kind of gasping for breath because they have respiratory issues, then a weaker voice, a softer voice, and then this is not going to be the person who's going to be able to sing up and down the scale because they won't have enough breath support to make all those changes in pitch range. So hopefully those all make sense to you. So that is the question of how would insufficient subglottal pressure affect phonation. This is based on what we know about how the vocal folds come together. Now, we said that it's important that the tissues be really elastic, right? We saw how much they have to move and in mucosal wave. So what would happen if there's a loss of tissue elasticity? What would happen, if that was an issue? How would it affect it? Well, in terms of intensity, you would have lower, so because the tissue is not able to come together, or you don't have that nice smooth movement, the nice flow of air, if the vocal folds are a bit stiffer. And then in terms of fundamental frequency or pitch, you wouldn't be able to control the pitch as well. So you'd have this pitch instability if the vocal folds are not so elastic. And then the quality of the voice would tend to be either breathy, because again, the vocal folds are not as flexible, or a voice that's more hoarse. So that would be how changes in the tissue elasticity would affect phonation. Now this picture is just shown in here, and we're going to show again, I'm going to go back to this because this is actually also an example of a voice disorder. This is called presbylarynx. So presbylarynx can occur as a normal part of aging, where there's a bit of a loss of vocal fold tone and elasticity. So you can see that the vocal folds are a bit bowed, right? So if they're bowed and there's a little more space than should be, for example, you can understand that the voice is probably going to be at least breathy, right? Because you have that bowed effect where there's sort of a bend. Bowed means sort of, bent a bit, just like if someone said a person's legs were bowed. So that's what we mean by that. And then, again, things like being able to control pitch, that would be at a disadvantage with presbylarynx. So you might hear more pitch breaks, and sometimes you might hear if a person's voice is very old. Again, I feel really awkward today because my voice is bad today, and I feel like, oh yeah, I probably sound like an old person's voice. But yeah, you might hear more pitch breaks, more cracks in the voice, and part of that has to do with the vocal folds and the changes that might have occurred just with aging. You're typically much older than what I am right now. This is not that. This is allergies and all that jazz. All right, so what about vocal fold approximation? How would changes in vocal fold approximation, and remember we said this is the vocal folds coming together for the purpose of phonation. So if there is problem in having the vocal folds come together to have that closure, to have that wave occur, how would it affect vocal fold approximation? And I'll tell you that, how would it affect phonation? And this problem with vocal fold approximation is typically what's happening, like if somebody has something like a vocal nodule, a vocal polyp, if there's something that's on the vocal folds itself, that's automatically going to affect vocal fold approximation, right? Because that means that something is getting in the way as the vocal folds are coming together. So in terms of intensity, a person's going to have more difficulty getting as loud. In terms of fundamental frequency and pitch, they're going to have more difficulty with pitch range. And in terms of quality, you will definitely hear a more breathy, for one. If you're not able to push the vocal folds together, you will also tend to hear hoarse, and you may hear strained. The person may be trying to really force the vocal folds together and sort of work around that nodule or whatever might be in the way. And again, with the other activities, you can hear some of these examples. Okay, so we're ending here. And please, whatever questions you might have about the slides that we just covered, please